Hi everyone, good evening. My name is Addy. I am one of the team members at Mind and Believe. I'm the webinar lead and I'm also an IMT3 working in Northwest London. I am here today to talk for our fourth session in the geriatrics series. In this particular talk, I'm going to be going over subspecialty geriatrics and liaison services, which is actually an increasingly large part of geriatric medicine. And I want to just highlight the role that geriatricians have to play in places beyond just the geriatric ward, as this is something that's only likely to extend and expand in the future. So just a quick series overview of everything we've done so far. This is, as I mentioned, the fourth talk in a planned series of 7 in total. So the first 3 talks, which are all available on YouTube, should you wish to watch them, have covered falls, fractures and mobility, as well as movement disorders, advanced care planning, and this talk today on geriatric liaison services. We have 3 further talks planned in the next month and a half. The next talk is in a couple of weeks on the 16th of September. So mark that date in your diaries. It's on frailty in younger adults, which is an increasingly common area of medicine. We're then going to have a very important talk on acute medical presentations in geriatrics, so the stuff that you're going to see on medical take or in A&E. And then our last talk is going to be on dementia and on other cognitive disorders. So lots more to come. And so in this particular presentation, here's what I'm going to go through. So I'm going to talk about the role of geriatricians in liaison services and in subspecialist roles. I'm going to help you identify how geriatricians contribute to multidisciplinary decision-making across multiple specialties, both medical and surgical. And I want to work through some specific examples of geriatric medicine in frailty units. So that's a front door frailty service, cardiology, renal medicine, orthogeriatrics, which is perhaps the original liaison geriatrics model, and oncogeriatrics, which is a new and evolving area of geriatric medicine. So let's talk briefly about where geriatricians add value outside of geriatrics. The most obvious place perhaps is in the acute medical take. So there's lots of geriatricians who also work in acute medicine. And this is obviously across the age spectrum. So it's not just people who are typically classified as patients in the geriatric cohort. Geriatricians are obviously also able to give lots of useful insight and clinical opinions on other patients as well. Front door frailty service is one of the things I'm going to focus on, and I'm going to start just going into that shortly. And this is essentially to reduce the risk of admissions, and I'm going to highlight why that's very important in a few minutes. We also see a lot of referrals from surgical specialties for ongoing care beyond just the perioperative period, and also optimization in the perioperative period itself, because this is an important part of medicine, and this is when patients are often at their most vulnerable. So orthogeriatrics is a very good example of that, and I'm going to talk through exactly what orthogeriatrics entails and how it's very important. There's also broader liaison services. This is often to help guide the direction of care and optimize treatment according to the specific population demographic. Obviously, geriatricians deal with people of a specific age day in and day out, and so they have a lot of expertise that they're able to bring to even kind of medical colleagues from other specialties, just based on the amount of experience they have. And then, given that we work in ever-pressured NHS with extremely long waiting times for a lot of specialty services, geriatricians are also taking on a lot of work in areas like movement disorders as well as dementia, because this is something that is seen very often in the geriatric setting. And so it's a subspecialty area of interest for a lot of geriatricians these days. So on that topic, the nature of geriatric work is evolving continuously. Life expectancy obviously continues to increase, but this does come with an increase in the number of people who are living with multiple morbidities. And this leads to a requirement for nuanced decision-making when it comes to what should and shouldn't be offered to certain patients. And when treatment is offered, the approach to how we make these decisions is often very different to what we do with younger patients. And this creates a lot of new challenges in terms of how we give people the best quality of life whilst also maximizing the appropriate medical therapy that they are on. So let's talk firstly about front door frailty. So frailty is quite a multifaceted and often quite nebulous concept. And feel free to pop any thoughts in the chat as to what it means to you. But I'm just going to highlight a few things that I think about when I think about frailty. So firstly, the British Geriatric Society defines it as a state of increased vulnerability to poor resolution of homeostasis after a stressor. In other words, someone has something that makes them unwell, and they're more vulnerable because their body's less able to adapt to what's causing the stressor. It's associated with things like low energy, slow walking speed, poor strength, and impaired physiological reserve, amongst other things. What does this mean in practical terms, though? So it means that there's an increased vulnerability to serious illness or disease. So someone who's much younger might perhaps be able to deal with something like a pneumonia better, but an older, frailer person may struggle with the same severity of pneumonia. If they do recover, which hopefully they will, then this often also results in a delayed recovery with longer lasting effects. So their baseline becomes much worse after this. And so this is an important point to just highlight. Hospital admission itself is a dangerous thing for older adults. This is a stat that was quite jarring, that up to 45% of individuals aged over the age of 75 in 2017 in England died during their inpatient stay. And this risk increased significantly for those admitted beyond 8 days. There's an increased risk of iatrogenic or nosocomial disease associated with longer stays. And there's deconditioning because of remaining in bed for longer periods of time. So people become functionally much more deconditioned than when they first came into the hospital. Acute delirium is also a real worry with these patients. Poor sleep-wake cycles, being woken very early to have blood tests, or if they're otherwise unwell, or if someone else in their bay is unwell, leads to very poor sleep. And this increases the risk of cognitive dysfunction quite significantly. Malnutrition is also a big thing, and this is often just being unable to access their usual foods at home. And because they're isolated from their normal social circles, maybe less comfortable with using things like phones to contact these people, they'll feel increasingly isolated, and this has impacts on their mental health. So I think this really flags up that where possible, we should try to manage presenting complaints for older adults in the outpatient setting. And in fact, this is very possible in the correct environment with the right sort of support. But it's really important to be able to identify this at the point of admission in order to streamline patients to the correct pathway. There's a few benefits of this. Number one, obviously, it increases the benefit to the patient. It avoids them having to come into an unfamiliar and often stressful environment. It allows for appropriate liaison with relevant specialist teams because there's a whole system set up around frailty services. And it reduces bed pressures in what's already a very overstretched system, which has knock-on beneficial effects for the wider population. So let's talk a bit more about front door frailty. So this is a service that exists to identify people living with frailty as soon as they first come into the hospital. And the purpose of this is to divert people to the appropriate services as quickly as possible, and if possible, to ensure discharge the same day or the next day if required. Why do we need to do this? Well, we've already touched on this. Evidence suggests that older people living with frailty, firstly, wait a lot longer to be assessed in A&E and then to be seen by medical specialists than other age groups, because they're often more chronically unwell rather than acutely unwell. So when it comes to triaging, people may think that they can be triaged to be seen a little bit later on. This does mean that their care suffers often because they do have to wait that much longer to be seen. Further, identification of frailty early on in their admission can help trigger an early CGA, or comprehensive geriatric assessment, at the front door itself. And this has objective links to frail patients being alive and living in their own home 12 months later. So the earlier this is done, the better it is for their outcomes, which is ultimately what we all want. However, if someone does get admitted, then older people have obviously a much higher risk of prolonged admissions, delays to discharge, and obviously morbidity and mortality. And because the frailty service is set up in such a way to specifically cater to these patients, there are often connections made between the frailty services and the appropriate community services, which are very useful in terms of plugging them into the right places to allow them to go home, hopefully on the same day. So firstly, who should be seen by these services? This is a tool that many of you are probably familiar with. It's called the Rockwood Clinical Frailty Scale. And it's a general screening tool. It's fairly rough, but it gives a very good idea as to who may be deemed frail. And this ranges from 1, so someone who's very fit, through 2, 3, and 4. Someone who's at a CFS of 4 is not dependent on others for daily help, but they have symptoms that will often limit their activities. And then further, we go from 5 to 9, so mildly through severely frail. And oftentimes, people who will be referred to frailty services are somewhere in that 5 to 7 category, depending on how unwell they are. So they're not actively dying from things, but they are frail. They are dependent on other people for a lot of things. And so they would be ideal candidates for a specialist service to avoid them from coming into the hospital. And then CFS 8 is very, very severely frail and often approaching the end of life. And 9 is someone who's already terminally ill. So this is just a general overview of how we can classify frailty. So what's the frailty team? Where does this team come in? So the members, obviously geriatricians, in terms of the kind of medical liaison for this. So they'll liaise with the acute care teams to identify those who are suitable for a frailty service early on during their admission or presentation to the hospital. They'll aim to exclude reasons for why patients might need to come in. So things like IV antibiotics, major electrolyte abnormalities, excluding fractures, etc. And essentially just ensuring that someone is medically optimized to be able to be managed in an outpatient or home environment. We then have physiotherapists. So if you ever worked on a geriatrics ward, you know the physiotherapists are a big part of the team. And their role in this setting is to assess mobility, identify potential barriers to discharge from a mobility standpoint. Occupational therapists who work closely hand in hand with the physios will often have specific liaison kind of connections with the community, and this allows for a rapid turnaround. So things like extra equipment to be delivered at home, increases to package of care. This can often be done quite quickly if it's in a purpose-built frailty setup. And they can also liaise with the community occupational therapists to continue care as an outpatient. So those are the key members of the team. Obviously, pharmacists and nurses and so on are all very, very important members of the frailty service as well. So what makes an effective frailty service? Well, we need to have the right team members who are all streamlined and purposely working in this environment. That's very important. We need to have connections between the frailty service in the inpatient setting or in the hospital setting and the relevant community teams to allow for those fast discharges that I was discussing. It's often also beneficial. So in my hospital, for example, there is a separate assessment area which has appropriate beds. It's often a lot less busy and a lot less stressful for these patients than the busy acute areas and A&E departments. There's specialist equipment and tools that are often available in these departments, which allows us to conduct a comprehensive geriatric assessment. And there's the availability of virtual wards in some cases, which can allow for continued care and checking in at home. So one of the tools that's used is something that I touched on earlier, the CGA, or the Comprehensive Geriatric Assessment. So what actually is this? Well, it's a multidimensional MDT assessment tool that identifies patients' medical, functional, social, and psychological needs. So it doesn't just capture health in one domain, it looks at several different domains of wellness. And it's a very useful screening tool that can be used to identify patients who might not need admission. There are objective links between this tool usage and better outcomes. So things like reduced readmission rates, improved ADLs or activities of daily living, and ultimately lower mortality rates. So let's go through how we conduct a CGA briefly. Step 1 will be a medical assessment. So what are the patient's active medical problems and comorbidities? Is there anything that needs to be optimized in that setting? And why have they come into the hospital today? Can whatever their acute medical problem is be managed in an ambulatory fashion through an appropriate outpatient pathway? It also involves proactively screening for under-recognized conditions such as delirium, constipation, and urinary retention, which can often present in quite a subacute fashion in these patients. Early cognitive impairment is something that can often be proactively screened for in these settings as well. Parkinsonism and osteoporosis are things that are not necessarily for inpatient management, but are important to pick up, especially when the signs are subtle and early. And then it's also a good opportunity to review someone's medications and think about if there's anything that could potentially be stopped or rationalized depending on the patient's general kind of clinical picture at this time. And there's some tools that we can use to guide our decision-making in this regard. I'd encourage you to look up the stop and start criteria. These are quite useful learning tools more so than anything else that can show us how best to decide what to do with a person's medications. Some high-risk drugs in particular would include things like opioids, some antihypertensives, and benzodiazepines. And also, the more pills that someone is on, the greater the chances that they'll be struggling to comply with it properly. So it's important to think about if there's a way to simplify this. Is it to do with how they are being given the medicines? Would they be eligible for something like a Dosset box? Or can we actually just simplify their medications? Are there options for us to actually cut back on some medications that may not give much prognostic or symptomatic benefit in this particular age group? It's a good opportunity to think about these things when you're doing a CGA on a patient. Furthermore, I think some specific things to always look for in these patients are falls risk. A fall in someone who's considered a geriatric patient is much higher risk than someone who's much younger and is associated with significant morbidity and mortality. So it's important to think about this. So look for things like evidence of postural hypotension, so lying and standing blood pressures at 0, 1, and 3 minutes, and get an ECG to look for any evidence of cardiac arrhythmias. Identify whether there's a risk to bone health. So a vitamin D level would be useful. If they're on long-term steroids, it's useful to think about whether the long-term steroids are increasing their risk of fractures, osteoporosis, osteopenia, and they may need to be started on vitamin D or calcium replacement. Further, nutritional assessment is an important aspect of this. Is there a suggestion that there's any underlying malignancy if they're particularly malnourished? What's their dietary intake like? Are they profoundly malnourished? Is there any evidence of AKI or dehydration? Moving on to sensory impairment, is there evidence of a neuropathy associated with chronic conditions like diabetes, B12, or folate deficiency that may be causing a sensory impairment, therefore increasing their risk of falls? Or is there an undiagnosed visual impairment which is leading to falls or medication errors? These are important things to consider when you're doing a CGA on a patient in frailty. We've already discussed rationalization as a treatment principle, but another example to think about is if someone's blood sugar control is too tight. So oftentimes we'll have a slightly relaxed approach compared to a younger patient when we're thinking about blood sugar control in older patients. So the risk of hypoglycemic episodes in older patients is much higher than that in younger patients. So it's just important to think about. Also, when we're thinking about rationalization of medications, overcorrected hypertension can result in hypotension, which also increases falls risk. So it's important to just think about how aggressively we're managing someone's blood pressure. Also, it's important to think about what the patient wants for themselves. If they have advanced frailty, typically this is arbitrarily a cutoff of a CFS of 6. Should we be thinking about advanced care planning? And if you look at the previous webinar, which is also available on our YouTube account, it's a really good talk on how we approach these topics. It may be that they need a referral to the community palliative care team, if this is appropriate and if they're happy to have this done, and involving relevant stakeholders, namely the GP, their family, their loved ones, and so on. And if appropriate, should a admissions avoidance plan be considered or commenced? This is only in certain patients, and it really is guided by the patient as to what they want for their own care. But if they're likely to just continue to deteriorate in the community, is them being at home something that's very important to them, particularly in the absence of reversible medical issues? So that's the medical side of it. Again, pop any questions in the chat if there are any questions coming up. But then let's talk about the various MDT members and what they add into the CGA. So physio and OT often have a combined role in this setting, and the main questions that they need to answer are how does the patient conduct their activities of daily living, and what help do they need with common activities such as washing and dressing, meal prep, shopping, toileting, and other common things that they'll be doing at home. And for these activities, do they have adequate support from those around them? So not only family members, but also care packages and so on. If not, do they need any extra equipment in the house, things like bed rails or stair lifts? Do they need any change to their home environment, something like a microenvironment or other considerations in order to be safe? And this is often an easier thing to assess in a purpose-built frailty setting rather than the very busy acute medical ward or the A&E setting. We can often have specialist equipment like stairs assessment tools and so on in the area, and it just makes things much more streamlined and much easier to do. Going through things systematically, how does a patient stand up? So how do they actually get up? Do they need assistance to do so? Do they get dizzy and so on? These are useful tools to kind of guide where we are with their general care. Once they are up, how far can they walk? And do they need any extra equipment to aid in their mobility, not only in their home environment, but also in the outpatient environment when they're walking around? And would they benefit from any changes to their home environment? Other contributors to the CGA beyond just the occupational therapists, physiotherapists, and doctors are dietitians. So they will be able to provide specialist input on maintaining caloric intake and referring to community dietetics if required for further supplements. Speech and language therapists, they would be able to assess for risk of aspiration and other suggestions of dysphagia. And it's useful to identify this early before it becomes a significant risk for the patient. They'll also be able to help bridge any communication issues. So, for example, someone who's had a stroke, it would be useful to get speech and language therapy involved to see how we can best manage their communication going forwards. Social workers are obviously a big part of this as well. They can liaise with the relevant community teams in order to see if there's any funding required for patients to be placed in a nursing home, for example, and they have a general awareness of the bed situation in hospitals. Pharmacy, of course, have a big role to play as well. They're an extra layer of expertise with regards to rationalizing medication, pill burden, using things like dosset boxes for medication compliance. So that's the first part of this talk largely done. And I just want to highlight kind of a summary of this bit, that the CGA and the frailty service is a highly effective tool to identify relevant service users to reduce the risk of people being admitted to the hospital and to reduce the readmission risk to help manage problems at the front door. It's a multidisciplinary setting with lots of various members of the MDT getting involved. And there's objective links to better outcomes for patients, provided we identify these patients at the front door. What about beyond that? Let's say someone does need to come in because they have other medical issues that do require inpatient management. Well, there's still a role for liaison geriatrics to play. And I'm just going to highlight a few examples of where this can be done. So specifically, I'm going to talk about cardiology, renal, and orthogeriatrics. Let's start with orthogeriatrics. I think this is probably the best known liaison model. Perhaps some of you have also worked in this setting. So what this is joint care between orthopedics and geriatricians. And this is most often done for patients who've come in with a neck of femur fracture in those over the age of 65. But sometimes also it will involve younger patients presenting with significant frailty. And this is an embedded service, so it's done from the point of admission. There's a pre-operative review period and optimization from a medical standpoint before the patient goes for surgery. There's then post-operative takeover of care. This is normally 3 days post-op to allow for sufficient time for any operative complications to be managed. And then ongoing rehab, discharge planning, and coordination, which will take place in the kind of coming days to weeks after the operation. So why does this actually matter? Well, hip fractures can often be considered a sort of sentinel event for the wider syndrome that we describe as frailty. So the estimates of 30-day mortality with a neck of femur fracture is between 6 and 10%. And so that's a fairly high mortality rate for any one pathology. And so involving the geriatricians early and getting them involved regularly through the admission improves survival, most importantly, but also things like rates of delirium, the speed at which someone can return to independence, and avoiding medical complications, things like infections, AKI, fluid overload, pressure sores. So the first bit of the assessment, the preoperative assessment, this should be done often while still in A&E, but really as soon as possible. And the key aims of this are to optimize medical stability for theatre. So things like fluid status, if they're anemic, controlling blood sugars. It's also important at this point to proactively discuss treatment escalation plans. So what is appropriate for this patient? Should they be for full escalation, i.e. would they be able to go to ICU if required? Should they be for an HDU level of care if required? Or should they only be for ward-based ceilings of care? And assessing for risk of delirium early with a tool like the 4AT is very important because this helps us to identify patients who are at risk of delirium later on and proactively take steps to reduce this from happening. Apologies, I think this is just a duplicate of the same slide. But the last thing here is just it's important to start to assess why the patient fell. And this will be more important in the post-operative setting. So moving on to perioperative management, people should be reviewed in the immediate post-operative period to optimize operative care. So infection, fluid status, delirium as discussed. And then from day 3 onwards is when the orthogeriatricians will take over. This allows for post-op complications in the initial phase, things like if there's failure of treatment, if they need to go back to theatre, this can all be managed by the orthopedics team. But then after that point, what does this involve? Delirium management, addressing what might have been reversible in contributing to the patient's fall. And what are some examples of this? Well, cardiac causes, things like syncope because of aortic stenosis or postural hypotension, cognitive causes, so delirium, dementia, and neurological causes such as Parkinsonism should all be addressed and proactively corrected where possible. Sorry, I'm not sure why this is duplicated again. But really, I think orthogeriatrics is the liaison model to follow. And there's a few reasons why I think this is the case. So there's structured, consistent input from the point of admission all the way through to discharge. There's an MDT model. So geriatricians, orthopedic surgeons, therapists, nurses are all looking after these very vulnerable patients. This results in reduced mortality, reduced length of stay, increased rate of people returning home. And I think actually this can be applied to a lot of other surgical specialties in order to achieve better outcomes for older patients who are often quite unwell. But it's not just in surgery that we can apply a geriatric liaison model, and there's a few other liaison services that are already quite frequent in medical settings. One of these is cardiology. So why might a geriatric patient present to the cardiology ward? Well, some common causes would include heart failure, so fluid overload, ischemic heart disease in patients who are not suitable for angiography, syncope, and AF or other cardiac arrhythmias. Oftentimes, these patients are less suitable for radical treatment options, both in terms of medical and more invasive care. And there's a role for rationalization of treatment interventions based on the long-term prognostic benefit versus the short-term risks of having people on these medications. Let's talk through a practical example of this just to highlight what I mean. So atrial fibrillation is a very common condition, particularly in older age. And there's an increased risk, particularly of thromboembolic events, things like stroke, up to 5 times compared to someone who doesn't have AF. So this obviously has the potential to have significant impact on quality of life and increases the risk of dangerous events like aspiration because of an unsafe swallow. So DOACs, things like apixaban, edoxaban, and so on, are very commonly used, whereas previously we used things like warfarin. The way that DOACs work is they inhibit factor 10, or thrombin, and this reduces the risk of clots being formed. But because we're reducing clot formation, there's obviously an increased risk of bleeding, including things like catastrophic intracranial hemorrhage. So how do geriatricians get involved in these settings? Let's go through a worked example. So let's say there's a patient, Betty, 81 years old, admitted to cardiology with symptomatic atrial fibrillation. She has an incidental finding of AF during this admission. And she has a background of ischemic heart disease, AF, hypertension, and type 2 diabetes. She's previously had a GI bleed, which required an emergency OGD, but her HP is currently 125 with a normal renal function. She's not on dual antiplatelets therapy. And cardiology have asked for a geriatric input on anticoagulation for atrial fibrillation. So how are we going to stratify Betty's risk in this instance? Well, the CHADS-VASc score is what we can use to do this. This calculates the incidence rate of ischemic stroke per 100 patient years. A score of 0 means that anticoagulation should not be recommended. A score of 1, anticoagulation should be considered. A score of greater than 2, anticoagulation should be recommended. And so I've calculated here, sorry, it might be a little bit blurry, but Betty's over 75. She doesn't have heart failure. She does have hypertension, and she has diabetes. So in her case, her CHADS-VASc score is 4. This means that anticoagulation should be recommended in this patient. But what's her bleeding risk? This is the important thing to balance this against. So the ORBIT score is a score that we can use to kind of counterbalance the risk of clots. And this is the risk of bleeding with anticoagulation. So 0 to 2 means low risk, score of 3 means medium risk, and score of 4 to 7 means high risk. So between 2 and so in her case, she's scoring because of age over 74 and bleeding history, because she's had a GI bleed previously. So her score is 3. So she's a medium risk patient, and there's about 4.7 bleeds per 100 years if she was to be started on a DOAC. So the big question is, should Betty be anticoagulated? Well, how might we approach this discussion? I think we need to involve the patient in the decision-making process. Think about what's important to her. So independence and kind of being able to manage on her own. Assess the patient's falls risk. So what's their home setup? Have they had falls in the past? And can we reverse any aspect of their falls risk? And the MDT is key here in terms of deciding this. This is just an important stat that I often use when I'm framing these discussions with patients. So a patient would need to fall 295 times in 1 year for the risk of a subdural hematoma on warfarin in order to outweigh the benefits of stroke prevention in AF. So this just frames that, it's not just that they have a very high bleed risk as soon as they put on anticoagulation. There's actually quite significant benefit to continuing someone on anticoagulation, even if they have a slight falls risk. It's just something to bear in mind when you're approaching these discussions. And DOACs, of course, carry a lower bleed risk than warfarin as well. So another thing to think about in Betty's case is her social history. What's her setup at home? So she's got a once-a-day package of care. She's mobile with a stick. She's not really had any falls before. And there's only very, very mild cognitive impairment. So she's fairly with it. She's able to manage her medicines and so on. So I think that on balance, Betty would probably benefit from anticoagulation. But what she needs really to decide this is a comprehensive discussion involving her family, any carers, physios, and OTs to help decide what's best for her. So how can geriatricians help in cardiology settings? So just important to say, the geriatricians are not the no team. We're not here just to say no to certain interventions or treatments, but they aim to provide context, nuance, and framing things in a real-world context for the specific patient. Some other examples of where, other than AF, where they might get involved is peri-procedural decision-making, so with valve replacement. So using a comprehensive geriatric assessment is useful to assess how frail someone is before we insert things like a PPM or an ICD or a valve. Will they meaningfully benefit even if they survive? There's also a role for geriatricians in heart failure optimization, so supporting appropriate rationalization of medications, addressing postural hypotension, and coordinating rehab and advanced care planning. Let's move on from cardiology. Let's talk about renal medicine and liaison renal services. So not all patients who are in advanced kidney disease or chronic kidney disease are suitable for dialysis. And in some cases, actually, supportive care might be more appropriate and often aligns more with maintaining patient quality of life. There's a really interesting study that I encourage you to look at from 2019 called the GOLD study. This is for adults with advanced CKD. And what it showed is that over the age of 80, dialysis actually offered no significant survival benefit over supportive care in those with frailty or high comorbidity, but it was actually associated with more hospital admissions and a functional decline. And these are things that are important to patients. In the oncology setting, oncogeriatrics aims to identify the areas of health optimization in frailer older adults using screening tools like the G8, the MUST, and the comprehensive geriatric assessment. And the goal is to give people the best chance of getting through chemo or radiotherapy. But sometimes I think it's also important to see this as an opportunity to think about what's important for a patient in terms of the, kind of achieving the best quality of life possible for them. So it's been a fairly quick talk. There's a lot of nuance to liaison and geriatric subspecialty services, but I just wanted to give an overview as to kind of some of the initial bits. And I'm very happy to give a further talk on some of the specific aspects of renal care, as well as oncogeriatrics. If that's something that's of interest, just let me know on the feedback form, which I'm about to give out in a second. But just to conclude, geriatricians can bring a unique lens to specialty care, both in the medical setting and in the surgical setting. The focus is on function, frailty, cognition, and what's important to the patient. And liaison models improve outcomes by shaping how we approach treatment decisions, escalation plans, and facilitating realistic goal setting for patients. Orthogeriatrics is a great example of what full integration looks like, but we can also apply the same principles to medical specialties, and this is increasingly being seen throughout the inpatient setting. And the role is not to just say, can we treat? It's also often to ask, should we? And the most important thing is to support patients in making these decisions for themselves. So that brings me to the end of my talk. Thanks very much for attending. I'm just going to put the feedback link in the chat, but feel free to scan the QR code as well. If anyone has any questions, just pop it into the chat. And otherwise, if there's anything else that you'd like to let me know in terms of further topics or points for feedback, please just fill out the feedback form accordingly. When you fill out the feedback form, this will generate a certificate for you for your attendance, so hopefully that's useful for you as well. But otherwise, thanks very much for attending. I'll leave the chat open for a little while, just in case anyone has any questions. But otherwise, I look forward to hopefully seeing you in the next talk.